Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I'm joined by Dr. Mike DePascale. Dr. DePascale is a fellow orthodontist who graduated at the top of his class from the Rutgers School of Dental Medicine in Newark, New Jersey. He went on to complete his 3-year orthodontic residency at the University of Maryland and graduated with a master's in oral biology in July 2017. During his time in Maryland, he researched the importance of assessing facial harmony and balance in addition to teeth, something that he continues to focus on when treating all of his patients today. Dr. DePascale joined Kozlowski Orthodontics as an associate and now co-owns and runs Kozlowski DePascale Orthodontics with office locations in New London and East Lyme, Connecticut. He and I have an amazing discussion where we talk about his personal struggles with sleep apnea and how that motivated him to pursue a career in orthodontics, the lack of training that orthodontic residents receive in early airway-focused patient care, the challenges with implementing airway-focused care into a busy practice, including tips on training your team members and how to create an interdisciplinary network of like-minded professionals in your community, how his young son's airway struggles opened his mind to the possibilities of treating younger patients, what motivated him to be a fitness enthusiast, how he prioritizes his health in spite of having such a busy schedule, and much, much more. You are quickly going to realize when you listen to this episode that not only is Dr. DePascale an excellent orthodontist who is a deep and critical thinker, he's an all-around outstanding human who is truly making the world a better place. So without further ado, let's get on to today's episode with Dr. Mike DePascale. Enjoy the show, everybody. Welcome to Doc Podcast, Mike.
Great to be here, man. Thanks for having me.
I appreciate you coming on. We've known each other virtually. We've never met in person, actually, as of yet. I'm sure that will change, but you aren't too far from where I was in upstate New York. And obviously, I know Jeff Kozlowski, your business partner. He and I were actually in a study group together way back, Progressive Orthodontist, which was this online study group that he and I were in and got to know each other through that. And then I've had some dealings with him through OrthoFi as well. But with you joined him when he was already established in his practice. So I want to hear about all of that, your journey in orthodontics as well as in life, as much as you want to share. You also have some interesting stories about what got you to this point in your life and career. So if you don't mind kind of going back as far as you want to go that you think the audience would like to hear about to start to paint the picture of how you got to be the Dr. Mike DePascale that you are today.
So I think I had a pretty cool journey on how I got to become an orthodontist. I actually just had this conversation yesterday. I interviewed someone and for the first time ever in my career, they asked me why I became an orthodontist, which I thought was really cool. I loved that question. Yeah. And I went on my whole spiel that I'll tell you guys right now. And basically, as a kid, I'll call it, in college, I had no idea what I wanted to do other than I wanted to be in medicine of some kind. My mom is, retired now, officially. Was a labor and delivery nurse for 30 plus years. I got pretty interested in the medical field just from her experience in it. Now, obviously, orthodontics is a far cry from that, but in deciding what to do, I cold called a bunch of different medical professions. I got a job as a physical therapy aide. I thought I wanted to do that when I was younger. And on top of that, I called a physician, I called an optometrist, I called a dentist. And I just went to visit people to see what I thought might be interesting. And I landed from that, in short, on at least attempting to go to dental school because I thought the field was interesting. I liked that when I was there, it had a balance of medicine and also other aspects that I thought were interesting for me as well as not repetitive. I looked at some things and it felt like the same thing was happening every single time and I never got that vibe in dentistry. So I just felt like it was potentially at least going to be a good fit for me. And right around the time that I maybe got into dental school, somewhere thereabouts, I had gotten re-diagnosed with obstructive sleep apnea. I had it when I was a kid at 2 or 3 years old, had my tonsils, adenoids out. Never thought about it again after that until I became an orthodontist and looked back at all those photos, which hopefully we'll get to in part of this. But
Yep, absolutely.
I had pretty severe sleep apnea. So from what I remember, I have these numbers somewhere, and I wish I had them for this. It would have been interesting, but my AHI was somewhere in the 20s, and I was physically in bed for 2 to 4 hours a night. And with that, having that type of sleep, and someone like you knows this, in my opinion, at least, that number is always deflated. So, whatever it says, it's probably more severe than that.
So, and I remember the impact of it is certainly more severe, right?
Yeah, exactly. Right. Whether, the impact of that is much greater. And when I look back at that, I mean, I got in 3 car accidents during that time of my life because I couldn't react in time. Just like silly things, like stopping when a car's stopping in front of me. I never truly fell asleep at the wheel, but I very distinctly remember situations where I dozed off. And I was thinking about this on the way here today, actually. Those little bumps on the side of the road that drive everybody nuts when you veer off a little bit and you're like, oh, that's so annoying. That probably saved my life a couple of times. I actually needed those. So that's a real story. I mean, I can smile about it now, but it was a very, very rough time in my life. And that was around the time I was trying to get into dental school. So trying to study and get ready for that at 2 to 4 hours a night of sleep. Fast forward, I finally saw a sleep specialist, and I got 3 options of treatment. CPAP was one. A repositioning appliance was another, although they did tell me at the time. Now, keep in mind, I knew nothing about any of this. But they did tell me that my situation was probably more severe than a sleep appliance, which I would agree with, or orthognathic surgery. And so I was CPAP at 20 years old or orthognathic surgery. And my thought was, I have to do something. There's absolutely no way in hell I'm wearing CPAP for the next 75 years of my life. So as big of a deal as that was as a procedure, it was kind of a no-brainer for me. I felt like it just something that needed to happen. And that experience, I used to tell this story and say it changed my life. I think I'd say it probably saved it. I actually have a different view on how that can be impacted now in terms of orthognathics versus other methods. But at the time, I mean, and not knowing anything, I really believe that I might not be talking to you right now if I didn't have that done. So that dentistry came of looking at other things. Orthodontics came as a result of that. I had a great experience with my orthodontist post-op, and it truly was a life-changing or life-saving, whatever you want to call it, procedure for me that got me really interested in the field. And I think that was probably the biggest aspect of it. And, when I went into dental school with the mindset of, if nothing changes in my mind, I think that's what I want to do. I also spoke to a lot of dentists at the time, and many people recommended orthodontics as a great profession. So you kind of add all those things together, and here I am. So that's my story on why I became an orthodontist. And what brought me here specifically to work with Jeff was a little bit of fate, I guess, luck. I don't know. I mean, I was fortunate when I was in my last year of residency. I got a number of job offers, and several of them were quite good. And I had the fortune of being trained in part of my residency by Tom Barron, who's a good friend of Jeff's and had been teaching with him for a long time on the Damon system. And, they connected when we connected, and through some conversations, I just loved what Jeff was doing and kind of what he stood for, how the practice ran. To be honest, at the time, I didn't know enough, even though I'm saying all this now about the way that we treat, to make a decision based on that. I was kind of an open book at the time. And it just happened to be that I really liked him and the way the practice ran, and his philosophy became mine, really. I mean, I guess the other way around, he taught me a ton, but he had already been thinking along the lines of what I do now long before me. So, and it ended up working out quite well.
Oh, that's awesome. And thank you for going into that detail. And I say it all the time, and people are probably sick of hearing me say it in the audience, but the stories that get us to where we are, it's why I love that. I love starting the show with that, because it's such a part of who you are today. Clearly, what you went through had an impact on you. I don't know how it couldn't. I mean, just 2 to 4 hours of sleep, and not even deep, restful sleep at that. I mean, it's a miracle. I mean, that you're still here with us and didn't have something happen or have such severe deficits that you had all sorts of other issues and couldn't pursue your education because you weren't mentally there to be able to do it. So kudos to you. Shows what a fighter you are and how strong you are to be able to fight through that. A lot of people would, and I know there are a lot of people who just can't fight through it. And when David Gozal was on the show, who's dean of a medical school now, but he's a brilliant physician who specializes in pediatric sleep medicine. And he was talking about that, the deficits that, and we can even get into that later if we want, but the deficits that exist in these young kiddos that we don't realize the impact it's having on them, not just then, but later in their lives. So you clearly had some people looking out for you above and guiding you through it. And the fact that you found Jeff, I have a lot of respect for Jeff as a colleague, as a professional. I know he was involved in the early treatment side of things, which we will get into that a little bit more, well before most people were, or was even really being discussed. He was definitely a leader in that area, and the way he pushed the envelope of non-extraction treatment. So it's really cool that you guys found one another. You had philosophies that aligned. Where are you from originally?
Not far. I'm from Northern Jersey. So,
okay. So it's
not here, but I had never been up past the Danbury line. So I knew absolutely nothing about this area.
That's interesting. So it went up to that spot. Well, yeah, it's just great. And you guys, I know your practice, and I'm not just saying this, it's a phenomenal practice. You guys do amazing work. You guys are amazing clinicians. And I'm not just saying I know that personally from people who've been treated by you and knowing Jeff. So I want to just get that out there, that for the audience listening, these are not people who are lightweights in the orthodontic skill arena. I think sometimes people think, well, people go into this earlier treatment and airway stuff because they don't know how to straighten teeth or they can't make it, doing regular work, quote unquote. That is not the case usually, and it is certainly not the case with you all. So on that,
thank you. Appreciate that.
No, my pleasure. And I mean it. Where did you, so I guess I'd say, because I want to take a little bit of time here, take a moment to help some of the younger docs out there, and this can apply in medicine and dentistry because we have a lot of physicians who listen too. What were you looking for in a job opportunity? Because more and more docs are coming out now with higher and higher debt. Corporate has really become a big thing. And I love the fact that you and Jeff kind of have a traditional practice transition model. He was a senior doc, you went in, you associated for a while, you end up buying into the practice, now you're co-owners. And I feel like a lot of young residents with whom I work feel like that's not really an option anymore. So what was it about that was appealing to you, and how have you guys pulled that off? Hey, everybody. Quick question. How many kids are you seeing who are mouth breathing, snoring, not sleeping well, maybe struggling with focus or behavior in school? You know something's off, but we're never taught how to treat these patients early. So we wait for more teeth, wait for maturity, wait for the permanent dentition. Meanwhile, that child keeps suffering. Well, it's time to change that paradigm, which is why I've partnered with Dr. Daniel Camacho to launch the Early Orthodontic Treatment Comprehensive, a hands-on, 2-day immersive experience in Fort Lauderdale, Florida, this November 13th and 14th. You'll learn to identify these patients early, read CBCT images, coordinate with medical and OMT colleagues, and deliver proactive dentofacial orthopedic treatment. You'll study real cases, then watch it done live on actual patients. So you'll return home with the confidence needed to implement it in your practice on day one. And the support doesn't stop there. The registration fee includes my full 26-hour online course, a live remote case review in spring 2027, and a full year of discounted coaching. And if you enroll by May 31st, you can save $1,000 off the registration fee. We're keeping this intimate, just 20 docs. So click the link in the show notes and grab your spot before it's sold out. We'll see you in Fort Lauderdale.
That's a really good question. This would probably be days of conversation. I don't even know how to best answer it, but so I can make it super simple. When I was looking for a job opportunity, I think if I could credit myself with one thing, and just philosophically and how I've advanced in life professionally, I'm not usually, I would never call myself the smartest person in the room, but I'm pretty good at finding that person and gluing myself to them. So when I was looking, honestly, I told you I had some good opportunities, and some of them I would say potentially better for me for a number of reasons immediately, but not better long term. I saw that with Jeff. To make it super simple, at that time in my career, and I'm still doing this now, I wanted to be with someone that I was just going to learn a ton from, and frankly, someone that I thought would be a really good mentor. And I didn't care necessarily at the time. well, I shouldn't say that. It's not that I didn't care. I did not know enough about clinical mechanics and how I treat now to be able to make an accurate judgment call on, do I want to like be with somebody because this is how I think my mechanics should be, or do I want to, I looked at it as, I want to be with someone that I love the way he treats people. I love what he stands for. I've seen what he does in the profession, at least to some degree at that time, and someone that I feel like I can really grow with. That was a huge aspect for me. So, and it worked out from a constant commitment to doing that. I've talked to a number of people over the years on, because as you've just alluded to or said, I mean, I was even told this at the time, that like all the partnerships fail, they never work out. It's like, that's just a general sentiment. And to be honest, like, did we have personality wise, maybe an easier time that some other people would? I guess to some degree, because generally speaking, there are significant similarities, but as I've learned over the years, there are some things about us that are quite different. And we've had to work through those, as you would with any relationship. So for us, it is, what I think we've done differently is a constant level of communication about what's going well, what's not. And it could be down to the most minute thing that's an inconsistency with us between the team, because we co-treat patients. So
okay, I was going to ask you that.
With few exceptions. Yep. And there is a lot that goes into that. I've seen that go very, very poorly for a host of different reasons. It's not easy. And I think we do a really good job of it. But even though we do that, it's still sometimes hard. And we, like, almost daily, we are communicating about something. Is it like and it could be, I'm not exaggerating at all, like literally the way a bracket is passed to one of us to be consistent with the team. But in terms of clinical mechanics and treatment and philosophy, anytime, like if either one of us sits down at a chair and there was a decision that doesn't seem like exactly in line with something that we would do, again, within reason, I'm not going to get into all that right now, but we'll talk about it. We'll be like, hey, what were you, why did you do this? Is it something different than what we've done before? Did you learn something different? And we'll talk about it. And that's, I'm not joking. It's at least a couple times a week, if not every day. And that's 8 years.
Yeah.
I'm still doing it. So that's what people don't do. And that's why it doesn't work out. And it's, some just because of personality and life goals and whatever it is, it could be more challenging than others, but I think we've always treated it as a commitment to each other and making sure that we are communicating and when there's a difference. And I'd be lying if I said we didn't have some really tough conversations over the years, just like you would in any other relationship that's really important to you. And it's like anything else. I think when I've seen them not go well, this is a little bit of a generalization, but it's almost always an inability to or lack of commitment to like communicating about things that need to be said. So, I mean, I think that's probably the best way that I could summarize it, which was a little bit long-winded, but to go back to it, I'll make it concise. I joined with him because I wanted to be somewhere that I knew I could grow. It's really that simple. Like the place that I felt like there was no ceiling. It was like, I'm going to get better at what I do. And that is one of the most important things to me in life, no matter what it is. And then, just constantly working on it from there.
Yeah. I so agree with you on that point and I tell residents all the time and I get asked all the time, and I've been teaching for over 20 years and been asked by residents constantly. And I tell them what's best for me isn't necessarily what's best for you. And for me to start my own practice, that was what I decided was for me, what I needed to do. But that doesn't mean that's right for everybody. But what you just described, and I absolutely love, is you had a vision for what you were hoping for in your professional career. And you knew when you were just describing it, you understood you wanted to be in a place where you would grow, where you had a mentor, where you had someone you could idea share with. And I just hope everyone out there in whatever profession you're in hears that you want to know where you're going to be. I call it the 20-year you, but people think 20 years, it's so far off. If you don't know where you want to be in 20 years, how do you know where you want to be in 2? It's like driving across the country, right? If you don't know where you're ending up, you could go 2 years in way the wrong direction. And yes, you could correct and get back on track. But if you could save yourself that and really have a more targeted approach, you may end up with a situation like you had. Think about it. You had all these other opportunities, and it doesn't mean that they were bad opportunities, literally. It just means they weren't what would have been the sweet spot for you. And it's really cool to see this working in a traditional way. I'm so encouraged by it. And I know a lot of people that have done exactly what you and Jeff did and had it work wonderfully. And as you said, it's like a marriage. It's a relationship. You have to work at it. But I guess just to be honest, if you don't want that, then don't do it. Then go work for somebody, right? Go do corporate, go in and check out in the morning, in the afternoon, work your days a week you want to work and be done. What I tell people all the time is don't get caught in one of those positions if it's not what you want to do. Would you agree with that?
Yeah, absolutely, man. I think, again, my path was my path. And I knew, of all the things I knew, one of the things I was positive of is I did not want to open my own practice. Not because of not wanting to do it. I just wanted to have a mentor, and I wanted to have someone to bounce ideas off, because I felt for me like that would propel me the most. And I think I was right about that. There's a host of opportunities I've gotten, and just a bunch of other professional things that have either come directly from being with him or as a side effect of learning things from him and connecting with people and whatever else. So it has worked quite well for me. But I know people that have been in practice longer than me that are associates and are super happy about it.
Exactly.
And that's what they want to do. I mean, there's pros and cons. You know this as well as anybody. And that's a different version of, it's not corporate, but you're still like in some ways a clock in, clock out. Now at 10 years, you probably are managing more stuff than someone would be at year 1 or 2, just because it's a natural progression. But you know what I mean? I know people that are perfectly happy with that. So if you know that, it's a great thing. And I think it's really important to just stick to how you feel about yourself. In particular in orthodontics, although I guess that's just the field that I know the most about, I do think that there is still this like really strong pressure of like, you got to be your own person and you have to open your own. And I don't know why that is. I mean, it doesn't have to be like that. Does work for a lot of people, but so do a lot of other things. So
completely. No, I completely
you got to know
agree.
yourself.
Talk to me a little bit about your education in your orthodontic residency and how that did or didn't prepare you for practicing outside of that once you graduated.
So I actually had a great experience. I went to University of Maryland for my orthodontic residency, and clinically, I thought it was very strong in that I got exposed to just about everything, nice. Which I think is a hard thing to do, and maybe it's different now because I'm coming up on 10 years, but generally speaking, I don't know that was a common thing that happened. And as a resident, in some ways it was a little bit confusing because I didn't know, like I knew so many ways of doing something and probably none of them well at that time. Mm-hmm. But it did really help me, kind of at least have an idea of what was out there and what I wanted to do. And I mentioned this earlier. I think that what shaped a little bit of I guess to go back to the fate part of it, I told you that joining with Jeff had nothing to do with his clinical treatment philosophy. It was more about what I could do with him and how he treated people and what he had done for the profession, less about the actual clinical mechanics. But of all the things I learned, when Tom Barron taught me the Damon system, it was the thing that clicked the most for me. It was the system that I felt like I knew what to do the most consistently. And so that I had an idea of that worked out for me because that's what Jeff was doing. And I mean, that was just happenstance. But again, in my residency, I think the biggest aspect was that I got exposed to a lot of different things. And I think that was really helpful for me in terms of just knowing what was out there. Now, the flip side of that is, I joke about this, but I actually spoke about this once at AAO about like partnership and pathway too. And, when you come out of residency, you think that you only know clinical mechanics and you don't really know how to manage people most of the time. And then like 2 or 3 years in, you realize you don't know anything about clinical mechanics either. And then you start fading out. So that, I think that's an important realization that I had. And like, when you realize you're like, okay, I have a ton to learn, then you can be back head down. And that's where having an opportunity, like a mentor like Jeff comes in and just continuing to educate yourself. But that I think was so preparation, I think as good as it could have been, but also important to realize, again, I say this half facetiously, but half seriously, the end of residency is like the beginning of your learning, in my opinion.
Yeah.
Like that's when it starts.
I completely agree with that. And like you said, in more than just the clinical, in managing staff and managing, you got a whole team to deal with a lot of times, and other doctors to deal with, and referrals to deal with, and the community to deal with, and sponsorships of local organizations. I mean, it just doesn't end. So it is just the beginning. And I think that's a great way to look at it. Did you guys get much exposure in phase 1 and early treatment, or was it mainly just approaches to kind of adolescent and adult?
I did actually. I mean, I couldn't pinpoint like how many cases there were and what the balance of it was. I mean, from what I remember, not a ton, but enough to at least be exposed to it. Now, most of it was expanders and 2x4s. And I did a host of different ones, Hyrax, Haas, whatever they bought.
Any lower expansion or no?
I did do lower expansion.
You did in residency?
Yeah.
Go Maryland.
Arnold.
Yeah.
Where you make the arch into a rectangle.
Yes. The rectangular Arnold arch. Absolutely. Yeah.
So I did have a bunch, and I also had phase 1 Damon mechanics from Barron. So
that's
like I
phenomenal.
said, it was, I really did I got a lot of stuff.
Yeah, that's great. Our director told us if he ever heard we were expanding the lower arch, he would kick us out of the program and take and if we'd already graduated, he'd take our degrees away. So UConn's very traditional when it comes to that stuff. We did not get to see many phase 1s at all, and if we did, it was literally just like a posterior crossbite. Did they talk airway? Did you have any? Was it part of the curriculum? Did you have any part timers or adjuncts who would talk about airway and sleep, especially knowing you went into it with way more knowledge about airway than the average orthodontic resident? Was it something that was discussed?
Not with any regularity. I mean, what I knew of residency and airway was you could do orthognathic surgery to help sleep apnea. That's the extent of it. I mean, if we can get into more on like what we do now, but not really anything about, okay, let me rephrase. I shouldn't say nothing. Because I did learn about things like adenoid facies and, growth in terms of that growth and development. But for what I look at now and how I educate patients and parents and how I'm treating, it maybe barely scratched the surface. I think it was probably what most people get. Like you do usually learn that if there's a significant airway problem, which translates basically to obstructive sleep apnea, there's not really a spectrum of things, at least not to my recollection, that you're learning in residency. It's you have OSA or you don't. And you're probably getting treated with orthognathic surgery, and that's the end of it. So pretty much that.
Yeah, and sadly, I mean, that's the norm. You probably had more discussion than most. Some don't even get into the orthognathic side of it. And really, just from talking to residents, teaching and speaking at a lot of residencies. And I think, I guess before I go, what are your thoughts on why that is? Why? And I've never asked you that specifically, like why you think that is the case.
Gosh, this is such a loaded question. I think it's a host of different things. And I don't, to be clear, I'm going to answer this the best way that I can. I don't know that I'm faulting anyone necessarily for this, but I think there's just barriers to entry in schools that there aren't in private practice for a host of different reasons. So there's just some natural stuff that happens there. I think though, for me, the biggest issue with it is, I'll say probably two main things that I can think of right now. And I don't, again, this is not a agree or disagree. It's just what's out there. I think the evidence in terms of cause and effect is very new, still developing. Certainly, I mean, this as well as anybody, not generally accepted by the profession. So there's that. And if that's the case, I think you could, in some ways, understand it's a hard thing to teach in a residency program if there's not like an accepted truth, so to speak, within the profession, which hopefully we'll talk more about. But the other thing is so there's the accepted truth and there's just the fact that it's not straightforward at all. It's not like a if this, then that. I mean, there's a whole list of things that I go down when I'm looking at evaluating someone. Do they even have an airway problem? How do we treat it? What are we looking at? How significant is it? There's a host of different things. And there's a lot of specialties involved in that typically.
Yes.
And I can talk about how we handle that in private practice now, but in a it's just a hard thing to get down to that level because there's so many aspects that go into it. It's always interdisciplinary. It's never not.
Yep. Agreed.
And I don't even know of a way that you could do that effectively, not to mention what I said earlier, which is like there's just still not a generally accepted way of doing it. So I think that makes it tough. And there's probably a bunch of other things we could talk about, but those are two big ones that I could think of off the top of my head right now. And then, I guess this is more of a private practice thing, but I know there's still a very pervasive conversation about scope of practice and like whose wheelhouse is this, so to speak.
Yeah, I agree with all of those. I think, and I definitely want to come back to some of your protocols, hearing a little bit about what you guys do, as well as the sort of accepted truths or dogmas that exist therein and within our profession. I think another one, and this is kind of, it's this big, again, talk about long-term vision plan that I have to try to be able to change the system, because I feel a big part of it is the system that in which we operate, meaning I don't know what it was for you in Maryland. I'm guessing it was probably similar, but most orthodontic residency programs treat 50% or more of patients on Medicaid. And it's a very high number of their patients, right? Yeah, because they're going to a clinic, it's discounted care, and you tend to be in areas that are underserved. So I've realized in teaching at many different residencies that a lot of this goes back to the 1968 Salzman Index, which is now the HLD Index, the Index of Handicapping Need Assessment. It was created for Medicaid to really only look at, when they call it a handicapping malocclusion, if you look back at those initial documents in AJO, the handicap was a social handicap. It was a handicap that you would not be as likely to get a job or be able to succeed and thrive in society because your teeth looked so bad, which is why it covers very little, if any, early treatment, unless there's a craniofacial syndrome or something borderline disfiguring with this patient. It doesn't count the primary teeth. It doesn't talk about early growth guidance, and so when the system is built to not treat those patients, and what does it cover? Extractions. At UConn, we saw plenty of 7-year-old kids walk in the door. We didn't see 4 or 5-year-olds, but we saw plenty of 7-year-olds. But what did we do with them? Well, we look at it. They didn't have a posterior crossbite. They had significant crowding, blocked out lateral incisors, going to be impacted canines. And we're like, we've got to pull some teeth. So we'd pull the C's and the B's if they're still there, right? See them back in a year or two and monitor their growth, and then pull the D's if they needed to, and then pull the 4s. And all of a sudden we're doing serial extraction. Why? Not necessarily because there's any evidence or any saying that that's the way you should treat these patients, or any lack of evidence to the contrary necessarily, but because the system is built that no one will pay for that child to get early interceptive care. I'm even taking airway out of it. Just take preventative sort of orthodontic. Let's just even talk teeth for a second on this. So I thought about that when I got into practice, Mike. I got in my own practice and I started seeing patients walk in the door. And I felt like every kiddo who walked in the door was like a 6-year-old, 7-year-old kid that I just described. And I was used to being like, well, I guess we'll have to pull some teeth. But the parents, this is over 20 years ago, the parents are like, why are we pulling teeth? And I would look and I'm like, yeah, I guess why are we pulling teeth? Like they don't have big teeth. I mean, we know from the classic article by McNamara, O'Connor and Howe in 83 and AJO that talks about tooth size. It's almost never big teeth. Like these kids don't suffer from generalized macrodontia on the daily. It's small jaws. And I was like, and that's how I started trying to expand and grow jaws, not with anything with airway in mind or ever. I mean, this is the early 2000s. And I was teaching back at UConn twice a month, and I would go back, and this was pre-PubMed on, you couldn't like Google and PubMed and query all these articles, certainly before AI. So I would go back to the hospital either early or stay late at night, and the days I would go back there, and I would go into the library, the very library I just spent 3 years and never looked at these articles. And I would pull articles from like Schwartz, Gratzinger, McNamara, Ricketts, looking at all this stuff that they were going in, from the 60s on, expanding the lower arch, slow expansion of the upper of the maxilla. And I'm like, wait a minute, this is totally antithetical to what I just spent 3 years learning, but it makes sense. So I would go back to my practice and literally just start trying it. And I would say to parents like, hey, look, if you don't want to pull teeth, let's try to do this. I can't promise you it's going to work, but I'm willing to give it a shot if you are. Yes, you're going to have some costs associated with it and some time and visits, but they're like, we don't care, because now they were paying for it. It wasn't that I was dependent on Medicaid covering it. So I had that ability to try it. And then I started seeing, holy cow, if I go in and just dentally expand the lower arch and then skeletally expand the maxilla, the teeth have room. And it's now, if they need a second phase, it's usually very straightforward and easy. And that was how I evolved in that. It wasn't until about 6 years later that I actually started understanding there was an airway role in this. And like people think like, oh, you thought airway. I had no idea. I'm embarrassed to say, parents would ask me, geez, Dr. Mike, do you think there's like, it's related that he isn't snoring when we go out on family vacations anymore, or he's more refreshed in the morning? I feel like he's sleeping better. And Mike, I'm embarrassed to say, I was literally just like, I don't know. I mean, I guess what we're doing couldn't hurt. The nose is connected, like, I guess if we're making the upper jaw bigger, I mean, it can't hurt the nose. I had no idea. So what are your thoughts on that? Do you think that's part of the problem, is like this system that the residency programs find themselves in?
For sure. I honestly, I never really thought about it quite like that, but I think you did a really good job of explaining that. But I do think that index itself there's so many problems with it. Oh. And I actually, when I started practice, the initial office that I was in was one that Jeff had bought. And I mean, doesn't matter right now, but importantly, it was like 90% Medicaid. And I was splitting time between there and with him. And I had that problem all the time.
Interesting.
And I never really thought about it quite like that, but it really is completely pointless for early treatment. It does absolutely nothing for them. They cover nothing. And that was a big issue. I dealt with that all the time. Even if you look at the index for adults, the scoring system it makes absolutely no sense to me. I guess I'll just leave it at that. I don't know.
Yeah, I mean, it was made almost 60 years ago. Why are we basing funding for this? And again, not to get too much off on a tangent, but just the bigger picture of this. Now that we know the implications we can have on airway and health, and for all these kids, which we'll talk about in a moment, that we are redirecting craniofacial growth and helping them out, again, not just ortho, but as an interdisciplinary team, how much money we're saving the system in the future. I mean, these are kiddos that we know from the medical literature that have neurocognitive deficits, behavioral deficits, cardiovascular deficits that stay with them in one form or another for life in many cases. Depression, anxiety, failed relationships, failed jobs, and occupational challenges. Because if you can't sleep, as you very well explained, here you are, this healthy, fit guy in your young 20s, and you are struggling to thrive. Now add 20, 30 years, and maybe someone who doesn't stay in as good a shape, you can see where life falls apart on these people. And I saw it looking at my adult patient base now, and I'm embarrassed to say this too, but all the adults I treated over the years, Mike, that before I understood this, that came in with like deep bites. Many of them had 4 premolars out when they were a child. And I say it all the time. I'm not here to say that the extraction of those premolars caused the problem. The way I look at it is they had the problem. The extraction of the premolars treated the symptom, because that patient couldn't breathe properly. They didn't grow properly. So they had crowding. And the only way the orthodontist knew how to deal with that, which is what we were taught, was just remove some tooth mass. So these patients had the problem all along, and they come into my chair as in their 40s, mid 40s, many of them divorced, on psychotropic meds, having all sorts of anxiety issues. And they were sent to me. Why? Because they're breaking their front teeth because of the attrition, which I had because I had no idea dealt with airway. I was like, oh, they're just like stressed because they're going through all this stuff in their life, which is what we were taught. And I'm worried about protecting the teeth, and the dentist wants me to open the bite so they can restore. And how many cases I treated that way? And I look back on now and I'm like, oh my God, Mike, they were sleep patients. And I had no idea. None.
Mm-hmm. Yep.
Yeah. I mean, so I think it's a fundamental challenge that we face in this profession to start to look at it differently. So on that, how do you guys look at it differently? And this is one little caveat here for people to understand. you guys run a very busy, very successful practice or multiple location practice, multi-doc, multi-location practice. And that is one of the reasons I really wanted to have you on to talk about this, because I gave a big talk for the Florida Association of Orthodontists a couple months ago. And when one of the big challenges that people say to me, I held this impromptu Q&A for like an hour and 15 minutes afterwards. It was great. And people were asking a lot of awesome questions. And one of them was kind of, how do you fit this into a practice that is really busy and centered around straightening teeth? So how do you guys do this? How do you fit the extra diagnostic time, the interdisciplinary component, the extra time with the parents and explaining all this, why you're treating a young child and not waiting till they're teenagers, and then communicating with your medical and myo colleagues? How do you do it?
That is a really good question. Like most things we do, a lot of consistent time and effort in doing so. It's not an easy thing to do by any means, as
Agreed.
you pointed out. And these conversations are, generally speaking, significantly longer than most of the other ones, and for a good reason. So this literally could be a whole entire day talk on how we do
a
this.
Weekend. We could do a weekend course on this.
And I've not really done this on stage, but Jeff has talked many times in the past about scheduling and how to fit people in and how to do all that stuff, irrespective of airway. Now that you add that in, and it magnifies it, right? So it's a lot of team education is a big part of it. So we're having our team dive into these things as much as we can. And interestingly, this is, like you said, you're embarrassed to admit some of the things that you've done in the past. I wish that we had gotten on this sooner, but as of recently, we're really integrating MARPing more into the practice, and that is a whole other host of stuff, right? So I'll give you an example of something. Like, we have a sleep questionnaire that now every new patient gets, and probably should have sooner than we did this, but they all get this questionnaire that I developed to go into the interdisciplinary thing based on feedback. I took the Michigan Sleep Questionnaire, which is what we had used for years in the past, and then talked to an ENT group. Actually, the place that you recommended, I love those guys. They're awesome.
Oh, good. Glad it worked.
Yeah.
Awesome.
So I've known them for a while now, and from meeting with them, talking about treatment philosophy, we've narrowed it down into much less questions on like, what are the most important things we need to figure out before we go in there and dive into that stuff. So I guess it's really, this could get as detailed as going into when we decide when to go into an exam like this. Like, that's literally part of what we do based on what else is going on in the clinic, and communicating with our treatment coordinator on what this consult's going to be, how long do we expect to be in there, what else needs to be cleared out before we do it. So it's really a team effort on all fronts, from the phone call the first time someone calls and we're asking the appropriate questions so we have insight onto that.
Thank you. Yep.
When the treatment coordinator then follows up with them, if there's any holes in whatever we needed to find out, they'll figure it out then. They're getting an airway questionnaire before they walk in the door that they fill out. So when they come in, not only do we have answers to those questions, and then the treatment coordinator is communicating that with the doctor before we go in and talk to the patient, but they also have it top of mind. Because one of the things I found with that is, as you would know, I'm sure, until there's a very significant shift in, I'm not even going to say dental profession, just medical profession on the implications of this, and it's getting there, but I still think we're a long way from it.
Yep.
It's very common that we are seemingly dropping this bomb on them,
Yes.
I saw someone last week and I didn't even know what to say. Like, I felt so bad, but she had an 8-year-old and a 5-year-old in the consult, both for airway questions. She had heard through word of mouth that we evaluate this. So she comes in, and I looked at her daughter, and I talked to her about ankylossia, and I said, she had narrow arches. She had already been treated phase 1 somewhere else, but in speech therapy, still dealing with snoring, stuff like that. She actually hadn't had her tonsils diagnosed out yet, but long story short, I showed her, I said, do you see this? She's got, this is a form of a tongue tie. And I started explaining it, and she just started crying. And I was like,
Mom,
I kind of froze, because I'm like, I don't know what's going on yet. I mean, I had an idea, but she was like, we have lived in 3 different states. She's seen 5 different speech therapists, 3 different pediatric dentists, 3 different physicians. No one has ever said this to me. And she was like, I had such a nightmare breastfeeding her because she couldn't latch and nobody was listening to me. And it's like one of those stories, right?
Yeah.
And we see that kind of stuff all the time. and it's like, I dropped this bomb on her and I didn't know what to say. Like, I felt terrible, but like, I can't undo any of the stuff. So I did what I normally do. And I'm like, listen, I could totally understand where you're coming from. I told her a little bit of my story, so I'm like, I know what you're going through right now. Cause I've lived it. But we're here now. Like, there's still things we can do. Yep. So we don't need to like go back to don't worry about what has happened now. Let's move forward.
Love it.
But the point is, there's, we have to have stuff leading up to that, because that happens all the time. And it happens more in adults when, you have someone exactly like you said, they have a 100% deep bite, and the referral is because they want to restore the upper anterior teeth and there's nothing left on the lower incisors. Yep. And then you bring up this airway thing and they're like, what? I've been seeing this person for 37 years. No Yep. one's ever said anything about this to me. And it blows up into this, whole entire conversation. Yep. So I think until everybody's on the same page, and Jeff and I are working very hard, at least in our small community, to make this happen, where that is, there's a collaborative effort on all fronts here.
That's great.
And maybe we can get into that. I guess that's part of it. Like we have a monthly sphere meeting. We have another education meeting almost monthly with a very similar group of docs. We've met with the ENTs in the area that align with what we're talking about. We've met with the primary sleep physician in the area. So there's a lot that we're doing to prepare for something like this. And in terms of the office flow, it's as many touch points as you can before they even walk in the door, getting as much information from the treatment coordinator on what they're dealing with. And then from there, it's just managing the clinic, like how much time do we think we're going to be in there? What else needs to happen in terms of scheduling, you moving other people around and who needs to be seen when. And that part, like I said, that would be a whole separate conversation, but Yep. The team is a very, very important part of this. Like they've got to know the right questions to ask, how to evaluate some of these things themselves. Like they even know some of the stuff to look at. They can measure the airway on the ICAP for us and have some of that conversation leading into it, so we can get an idea where the patient or parent's at, and then we kind of take it from there.
Yeah, so many good points. I want to touch on a couple. The team, thank you for saying that. That was hard when I implemented that in my practice, because they hadn't heard me speak like this before, right? Like all of a sudden I'm speaking about airway, and we got our CBCT, our low-dose CBCT in 2014, and now we have to training our clinicians on different protocols and processes, and that is overwhelming for a lot of people. But it's just like anything. Once you lead and train and show them, I can vividly remember times where my TCs would come to me and they would be so excited. They know, they're smart, they're doing this, they see you. A lot of it is repetitive at that point. They would already be able to detect that there were a lot of these problems, and they would be so excited because they knew we were going to change this kiddo's life. And they're like, oh my God, I can't wait for this one. I can't wait to see where, he or she is in a year, because they would see this child that was suffering with all of the signs and symptoms and clinical comorbidities of sleep disordered breathing from the diagnostics that we had put in place, to your point, before I ever walked in that room. And, I talk to and coach people who are spending, an hour trying to go through the diagnostics and the new patient exam. And I'm not here to tell someone you can't do that. I mean, honestly, do it how you want to do it in your practice. I'm just saying not everybody can allocate that amount of time for this. And I can tell you, if you don't use team members, it might take that long. But if you are struggling, if you're out there and you're finding this is just taking a long time, do exactly what Mike just said. Train up your team members from that new patient call. When they get a young kiddo, have them have scripting for what to ask, explaining what early treatment is. Because if you don't, parents come in thinking they're coming in for a blocked out lateral incisor at 6 or 7 years of age. And now all of a sudden you hit them with like, their child doesn't breathe well. You've got to see the ENT or the allergist. It's too much. People just, they glass over, they shut down. But if you've prompted them along the way in your educational materials that you either email and or snail mail to them after they schedule their new patient examination, right? Send information about pediatric sleep disordered breathing and airway. Have your team members up front be tight on their scripting. So when parents do call and ask something about airway, they at least know how to provide accurate information and not just say, oh, the doctor will go over that. I mean, that's so big, and it's so often overlooked. It's actually one of the things that in my course, my online course, and then I'm running a course this November, an in-person course with a friend and colleague, Daniel Camacho in Fort Lauderdale, in his office. One of the reasons we're doing it part in office is so people can see how to work this into a team, because it's all well and good to just learn a technique. Great. We can teach orthodontists or to do anything like that, but how do you incorporate it? And I'm so glad you mentioned that part about the team, because I feel like that's so often overlooked. And as doers, we just kind of try to take it all on ourselves. And it's like, well, I'll do this and I'll do that. Yeah, you need to be the one to do the final diagnosis and present the treatment plan. That's your job. But who gathers that information and preps the parent and patients and gets them understanding what we look at and why we look at it and starting to answer a lot of their preliminary questions? Delegate that, right?
Yeah, well, as most of us know in the profession, most orthodontists are not great at giving up control of things. So that's generally a tough thing for people. And I mean, we all are, but like you said, delegating is super important. And I mean, I just want to say one more time, this is a much bigger hill to climb, but if you've got a core group of people in your community, and hopefully you do, if you don't, you should find them. Getting them on the same page with this is super helpful, and we do have a long way to go with this. But in particular,
Mike, but are you referring to like general practitioners, pediatric dentists, allergists,
I'm talking
ENTs?
Collaboratives, whoever it is, right? So we've met with all these people. It's not just like, hey, we're referring to the ENT. Like we sat down, we had dinner with them, we talked about our treatment philosophy, we learned theirs. It's like, are we on the same page? And okay, yes, great. And we're not with all of them, right? So some of them we're not. It's like, it's not like we're not going to work with you, but we know. And you know, and like that's not where that specific patient is going to go. And when they do, it's like from that conversation, like the ENT is a good example because this wasn't that long ago that we integrated a new group into our practice, so to speak, working with them directly. And even down to what do you want on the referral? Like what information do you need? X, Y, Z, like every single one of those things is talked about so that it's a streamlined process. And in particular in the airway space, because there's so many moving parts, and this is a little bit of a tangent, but I think one of the toughest things about it is if all those people are not on the same page, this will change. I know it will at some point, but for right now, the average patient is not thinking about the dentist as someone who's talking about their airway or knows enough to be discussing it. And because of that, in my experience, if one person in that line disagrees, you're done. Like if I refer someone to get their tonsils and adenoids out because of all the stuff we're talking about, and they go back to the pediatrician, the pediatrician's like, no, I think you're good. You're done. You're never getting it. It's not going to happen because they're supposed to know and we're not. So I think that's a big part of it. So we're trying very hard, and just to, we don't have to go into MARPI, but we have a prominent prosthodontist in the area that's a fantastic one. And she just went to, we actually had Jeff and the primary periodontist we work with and the primary prosthodontist we work with went to Winds of Change. I went to Ilya Lipkin's course and we kind of did a divide and conquer. We talked about all those things. And now she's telling patients about it for us. So they're coming in with like all of this knowledge already. So again, it's not like we're having this whole entire conversation, because that conversation is a lot quicker than this is the first time this patient's ever heard about anything airway. And then you're talking about MARPI, right? So
such a good point. Again, I'm so glad you said that.
It's a bigger hill, but I think it's important.
It's so true, because in my practice, the pediatric group that I worked most with, they set the patients up for us in a good way. And that's another great point is they came in, that pediatric dentist and that general dentist plays such an important role in seeing it. And if we just sit there as orthodontists or whichever, sort of like you said, whichever link in this chain you are, if you're not in line with the others, it literally can just blow the whole thing up. Conversely, if you have those primary care providers that you take the time to educate, which again, yes, this is time, it's energy, it's effort. But man, when you put that work in, it's like so many other things. We'll talk a little bit about the kind of the fitness side of things too. When you put that hard work in, it comes back in spades, and you end up, when that patient calls your team and says, Dr. So-and-so said that you could maybe help my child the way they breathe. And also you have a machine that will see, and maybe he or she needs to see an ENT or an allergist. All that work and that convincing has been done for you. And so you got to sow those seeds early in your community. But that's such a great point. A lot of the orthodontists out there feel like the other providers either should know or do know. And I love that you just brought that up, because they don't. None of us did. None of us got this in our training. We're all having to learn this after, right?
Yeah, for sure.
On that too, so early treatment. What is too early for you guys. And if you want, I know you have a bit of a story with your son as well, whatever you're comfortable sharing with that. But I get that question from so many people all the time. Like, why would you expand a 3-year-old or a 4-year-old? What do you say about that? I don't want to slant your answer one way or the other. I want to hear your thoughts.
I'll hit it. I'll take it right from there. So I think this question is why this space is tough. And not in a bad way. It's just like there's no generally accepted answer to that question. You ask that to 100 people, you're going to get 94 answers, right? So I think it really comes down to you have to have a system for how to evaluate it. And like anything else, then you decide what's appropriate and what's not. And I'll give a good example of my son. I'll just go right into that now. Orthodontically, I think the youngest person I've ever treated was 6. So I haven't done a lot of like very young, although I just saw a 5-year-old the other day. And I talked to his mom about like when is appropriate, how do we want to handle this? It was just an honest conversation. We decided to wait. I was open to doing something at that time, and I talked to her about that because he was having a lot of challenges. But so orthodontically, I don't know if I have like a super straight answer for that. I've never treated someone that young. It's certainly not to say that I'm not going to, and my son might be the first one to be honest, because he had a frenectomy, a lingual frenectomy at a few weeks old. Had a lot of trouble breastfeeding. It was our first kid. Like the whole situation was super tough for everybody, least of which me, obviously. But it was hard. And thankfully I knew enough. And, my wife, I believe, is a monofunctional therapist. She's, trained physical therapist that specializes in head, neck, and jaw. So she treats TMD and she does myofunctional therapy as well. So she had a pretty substantial amount of knowledge on this. And, we knew there was a problem. We addressed it right away. That was super helpful at the time. And as we kind of went further looking at him, I'm looking at my son and he's like me. I give him my airway, which is a really bad one. So I'm seeing things a lot differently on my side now. And we actually had him doing some, my wife was heading this and she's the myofunctional therapist, but we've had him start to do some of those things. And I will never be able to prove this, but I was very, very aware of his situation and what was going on and how he slept. And he always had an open mouth posture and, just keeping an eye on, and he's a great kid. He's always been a great kid. He's smart. He never really had any significant deficiencies, but I'm thinking about what happened to me at 7, 8, 9, 10 years old. And then what you were talking about, like what happens 20, 30, 40, 50 years from now. Right. And like, we were on top of it. So we had him doing some of those things. And in his first winter, I believe it was his first winter of life, he was sick all the time. And so I got connected with the ENT group for you. So thank you tremendously
You're welcome.
for this, because it was super helpful for him. So, fast forward, we had all of that looked at. He had his tonsils and adenoids out at 2 years old. And that was October, this past October. And it's all just symptomatic, subjective data right now for what we're talking about, but sick way less. He had 3 double ear infections inside of like a month when he was in his first year. It was really, really rough. He was sick all the time. And so little that I don't even remember a time that he was significantly sick this past sick season, so to speak.
Wow.
And this is something I wish I had taken better photos of, but he was developing an anterior open bite very early. Yep. And it's better. It's not gone. There's going to be things to work on. I think he's still going to have some deficiencies, which is why I'm saying he might be the first 3-year-old I put something in to see, but he's way better than it was before, from having the frenectomy done at a very young age, having tonsils adenoids out at 2 years old. And even doing some myofunctional therapy, which whatever he could handle, I really do believe that was beneficial in some ways. Now, there's a whole conversation about compliance, and it's tough at 2 years old,
Yeah, sure.
So generally speaking, that doesn't go super well. But again, as long as you have an expectation of, this is a no risk, we're going to see if it does some good things, because there's nothing else really. We've done all the other things. We know there's a problem. And we're gonna do something about it as to the best of our ability. And now I'm still looking at, he still doesn't breathe with his mouth completely closed at night. I know he's a little bit narrow. He's probably gonna need to do some more tongue retraining when he can. or when can more effectively and more consistently. So I might treat him at a very early age. So I don't know that there's a too soon. I think it's a balance of all of those things. It's like, at that age when it's really young, it's like, how significant are the symptoms and what do we want to do about it? But generally speaking, nothing is not my preferred option ever if there's something going on,
Right. Yeah. I completely agree. And it's interesting because it was recently in the doc community online, and thank you, by the way. You're one of the few who has the courage and the wherewithal to fight some of those fights with me on some of our colleagues who like to say some pretty nasty, pretty awful things to us when we dare question the establishment and the sort of accepted truths, as you alluded to before. So I appreciate it. It's always good to have a little support there and have someone going at it with me. But in my doc community group on Facebook, it's kind of nice. I've built it to be not just all orthos. It's got myos and orthos and GPs and pediatric dentists and ENTs and sleep physicians. And it's really a much more interdisciplinary group, which is why I built that. And I put a link in every show notes if people want to go join. But it's over 1,000 people now. And I literally started, I don't know, like a year and a half ago, just saying like, hey, like, let's throw this group together. And what's nice is you get you get a nice composite of people who think in different ways. And there are orthodontists in that group who don't really align with the way we might on airway, which is fine. And one of them, someone was talking about expanding a 3-year-old just recently. And one of the orthodontists said, why in the world would you ever expand a 3-year-old? And Mike, it was a perfect juxtaposition of why we're on opposite ends of this spectrum. That particular orthodontist was looking at it from a tooth only perspective. Right? I call it straight teeth bias. We have straight teeth bias because we're built to be these great tooth straighteners. And in his defense, if you're just looking at the teeth, why would you ever treat a 3-year-old? That being said, when you look at it from an airway perspective, and the person replied back and said, because my priority is to get this child nasal breathing, and they are a chronic mouth breather who is snoring. Because when you know the medical literature and when you understand that mouth breathing alone, let alone snoring in young kids, can lead to neurocognitive problems, behavioral problems. Just the mere fact that incidence of infection, as you were talking about before, too, where the nose is there to moisturize, filter, humidify, purify, pressurize the air, incorporate nitric oxide into the oxygen from the perinasal sinuses, which I just learned recently from my ENT friend David McIntosh. I always thought the maxillary produced the most nitric oxide. It's actually the ethmoids. And so, that means that air has to get up there, right? And up into the ethmoids and circulate and get down to the lungs. That promotes better oxygen exchange in the pulmonary vasculature. By relaxing the smooth muscle in the arterial walls, allows for better tissue perfusion. It's all connected. So my question back becomes, why would I want a 3-year-old who's chronically mouth breathing? Now, that being said, I'm not going to sit here and say expanding is going to solve every mouth breathing 3-year-old, right? It will solve some. But to your point, it's an interdisciplinary problem. So we check adenoids and tonsils. We check nasal passageways. If they are narrow and they don't have enough space, we expand. If the tongue is tethered and it's significantly inhibiting the ability of the tongue to do its work and be nature's expander. And I show an article from Principato in 1991 quoting Enloe from 82, his textbook, talking about this exact thing. This isn't new. When the mouth is closed and the orofacial musculature is relaxed, the tongue should be sitting up on the palate and causing outward and upward movement to expand it. When you don't have that child is not going to grow properly. And most orthodontists, when you explain this to them and they kind of take their dogmatic hat off on like hey, we don't treat young kids, we just need to change the way we think about it and say, we don't treat young kids to just straighten teeth, but why don't we treat young kids to be the dental facial orthopedists that we are, right? I mean, am I wrong?
Yeah.
We need to change the way we think about this. I think that's part of the problem.
I think that's a big part of the problem. We are, of all the interdisciplinary people involved in this scenario, we're the only ones that can do that. Like we are outside of surgical correction, which is a whole separate conversation and not something you're going to do at a 7-year-old. Right. We're the only people that can actually change the skeletal structure and the balance and how all of that stuff works properly. And, the other aspect of this, I think, is to make it super simple. Like we're just trying to normalize the skeletal structure to be what it's supposed to be. They work together. We had a patient yesterday that this is a completely different situation. It was an adult with generalized spacing, but I think she was 18. But mom asked me, is this functional, is it aesthetic? And without going into all the other stuff that I said, I basically summarized it as they're never mutually exclusive. There's almost nothing in orthodontics that doesn't have both of those benefits. Things that function properly will look good. So it's never really
same thing. Yep.
Just about moving teeth. Like if I'm putting them in the right position that is going to give you facial balance and facial harmony, there's going to be an aesthetic benefit of that. But it's because we put the things in the right spot. So they're definitely, it is absolutely a philosophical difference in thinking. And this is maybe a little bit of an unfair assumption, but I'm going to say it anyways. I lived this as a kid. And now my son is living it. Now I'm way more on top of it than anyone else was. And I don't fault anybody for that. I think it was a long time ago. This wasn't something that people were thinking about as much. We didn't know as much. There's a host of different factors there.
Sure.
But again, this is an unfair generalization, but I think that tune changes when it's your kid. I've had these conversations with people, but then when it's my son that can't breathe and is sick all the time, and now I already was thinking this, I'm not saying my is me, but like when you have that situation, the likelihood that you're just going to say, "Oh, well, I mean, there's no indication for that right now. Let's just see how things go." I have a hard time feeling like that's how most people are going to respond to it. And that was a very common sentiment that I got from other ENTs in the past, which I'm sure you've dealt with this a ton too, is this idea that, well, tonsils and adenoids are generally speaking inflamed at, 5, 6, 7 years old, and they're just going to grow out of it. And having lived through that, now when I look back at photos as a kid, where everyone thought it was cute that my mouth was open at 5, 6, 7, 8, 9, 10 years old, and then go to my sports life there, and then shortly after that in high school when I was overweight and out of shape and I was the last one running and I had sports-induced asthma and I was sick all the time and all these other things, I'm like, this was so preventable. And I'm looking at these photos and I'm like, God, if it just had been picked up, it could have been treated. So my argument is always, and unless this changes my mind at some point, will always be, what happens in those formative years? Let's say they do grow out of it. You look at a kid at 6 years old and you look at him at 12 and it's like, great, his adenoids are gone. But what happened in those 5 or 6 years that could have gone better? I think that's something that we really need to think about differently.
Without taking the time that we have together, I'll just tell people, if you haven't listened to the episodes with David Kozlowski, who I mentioned before, he's one of the leading sleep researchers, I think, in the world. I think he's been cited almost 100,000 times now. He has published so many articles. He's like over 1,000 articles in the leading sleep journals in medical literature. It's brilliant. He was on the show. He talked about that exact part, about even if you do outgrow it, the consequences therein. And David McIntosh, who was on episode 155, who's an ENT from Australia, who I just was with at PANI, which is a great meeting that Steve Lamberg does on Long Island. And David spoke as well. He came with me and Bill Harrell, and we spoke to the Montefiore Ortho residents. We had a great time talking to them. He talked about exactly what you were saying about outgrowing it. And on the podcast episode, he talked about and taught me something I didn't know about Scammons curves and what they really are and how they were really developed in the early part of the 1900s. So we learned that the kids outgrow and their adenoids shrink. It is a fallacy that is due to Scammons curves. And it's really interesting if you look back at the original document. So I'll just, again, let people go find that for themselves so we don't take too much time on it. But it is, to your point, waiting for them to outgrow it. People want like evidence of that. Fine. Okay. Maybe in some kids, the lymphoid tissue does shrink. Sure. Absolutely. We can show that happens. But what are the deficits that happen in the meantime? And what if it doesn't? Because it doesn't happen in everybody. Just
going to roll the dice.
So just take the chance. I tell you what, you got to, even if it's 50-50, like, what are we doing? If it's your kid, and the other point I want to follow up on, I can't tell you, Mike, how many of the people with whom I speak, work, coach, lecture at when I'm out presenting somewhere got into this because it was their own kiddo. And a lot of them who got into this who are non-orthos, if there's pediatric dentists or general dentists who got into early treatment that's airway focused, they didn't want to. They tried to send their child to the orthodontist first. They tried to send their child to multiple orthodontists first. And every orthodontist told them, too early, too early, too early. And they were like, but I can't let my kids suffer. So they went and started going to CE courses and going to figure all this out and trying to learn more about it. And I tell the orthodontic community all the time, like, you're seeding this space to others because, as you said, and I say this openly to pediatric dentists and general dentists, they agree. The orthodontist is the natural one to take this over, right? Like, who's involved in cleft craniofacial care from kids at a young age? The orthodontist. Why? We go to school for a lot of extra time to learn how to guide craniofacial growth and development, hence why they changed the name of the specialty and added dental facial orthopedics in 1994. Why would we not want to do that? And I think it just comes back to where we started this conversation. It's hard to fit it in our practices, and we didn't learn how to do it, so we don't really know what we're doing.
Yep.
Yeah. Before we wrap up, I just want to... It's been an awesome conversation, by the way. I thank you for sharing so openly on this stuff. I could sit and talk forever about this, but I want to respect your time. But fitness wise, so you talked a little bit about that when you were struggling with your health issues, you weren't in the best shape. That's another big thing, right? Look at all the childhood obesity and all of the issues with childhood fitness and how much of that is tied to children who maybe aren't sleeping or breathing well. Tell me a little bit about your fitness journey. We have that in common as well. We're both kind of fitness buffs and really into this whole world. So how have you maintained your Well, number one, why? Why have you made that a focus, and how have you done it? Because I know a lot of people who get into their 30s and 40s who want to be active in working out, but their practice, their job, their kids, it just starts to take so much time and energy that it gets hard to do it. So why is it so important to you, and how have you maintained that as a focus?
Okay, I'll try to keep this within a reasonable time frame, because this I could talk about for a long time as well. But why it's so important to me is probably, I would say, two main things. Now it's very different now that I have kids, and that's definitely the driving factor. Now I'll get to that in a second. Mm-hmm. I think having gone through what I did as a kid and remembering what it's like to be last in every sprint and all of that other stuff, there's a mental aspect of that that's kind of like, I mean, I'll just say it. It's like a look at me now thing. There's sure. Definitely part of that. Because I remember the first time I ever tried to run a mile, I couldn't make it. Like, did not survive a mile of running, which is absolutely crazy thing for me to say right now, because my fastest mile ever was a 4:53, and I'll never forget doing that.
It's insane.
And I don't know a lot of people that can do that, right? So there's a lot of people that can, the marathon, they just broke a 2-hour marathon. So there's guys that are smoking me for, 3 hours, but you know what I mean, though? Like, I couldn't even finish a mile to get to run something like that, which is something most people really won't touch. There's definitely some of like, I'm going to show younger me and show the world. And there's some other, things I went through as a kid that play into that as well. And I think the other aspects, I feel like where as humans, we are, for better or worse, I used to think this was a bad thing. Now I really don't. I think we're not mostly, but at least partly motivated by some fear. And to get really deep on this for just a second, I have one fear in life, one single thing. And it is feeling like I could have done more. Not just done more stuff, like been a better person, been more for my friends, done better for my patients. And in a physical sense, that's true as well. Like, I want to feel like I gave absolutely everything that I could. And so that keeps me going all the time. And the third thing, which is a huge thing with kids now, I just look, and I had kids later than average. So I'm, 40s coming up. I'm 38 now. My kids are 2.5 and 1.5, just about. And when I think, when I fast forward, I'm like, man, my son's going to be, graduating high school. I'm going to be in my late 50s. And I want to be able to hang with him, like I have I've got some fitness goals tied to that. I want to be able to I haven't decided the distance yet, but I want to be able to beat him in a race until he's 15 is my goal, which is going to put me at 50. And then, so there's some things there, but I guess, in terms of that side of things, like what really keeps me going, and me, but other people don't in this aspect. I've competed in powerlifting. I've competed in CrossFit. I'll probably compete in some other things, over the course of my life. And those are consequences of the action. They're not really the goal, even though I make them goals along the way. It's really a byproduct of how I want to see myself. And some of it is like, I want my son to see me. He just did it this morning. I did a really hard workout this morning, and he came in from a walk with my wife and watched me in the garage for the last 5 minutes, which was the hardest part of the workout by far. And I want him to see that. Like, and my daughter as well. I mean, she's too young to appreciate it, but I want him to not see me crush a workout. I want him to see one that's crushing me and me do it anyway, you know? So there's a huge part of like, I want him to grow up that way because I did not. And I also want to be able to, you know, not be the dad that has to sit down walking through Disney because I'm tired after, you know, being on my feet for 2 hours and my knees hurt, you know? So that's definitely even though that was long-winded, that was a concise version of my why. And the how is a balance of things. So I'll talk about the word balance and how I view it. But I would say it's really just a commitment to doing something that's important to me. It is absolutely a non-negotiable for me. There's not even a question. Now, I want to be clear about this. Like when I was a resident and I was single and I had nothing else to do with my time, I was training twice a day for 2 hours a day and I love doing it. There have been times over the past few years where I went months and I never had longer than a 15-minute workout. And that's not an exaggeration at all. So people, when they know of my fitness, they think that I'm like always on all the time. Not the case. I mean, I've gone through the same waves as everybody else. It's just a decision to do it anyway. So this is a very cliche thing, but I think the mindset and actually saying this out loud to yourself is really helpful. Of switching, I don't have time to, I'm not making this a priority is really, really helpful. Because you always have 10 minutes. Like there is no way that for any length of time you're going through, and I've had 7-minute workouts plenty of times in the past because that's all the time that I had. So I have just done it for so long now that it is not even an option in my day. And, and I think, you know, a big part of that too is understanding that, and I struggled with this a lot, having gone through the competitive mindset that I had, not that I don't have it anymore, but like being in actual competitions, I struggled transitioning from this is an ideal workout. And like, I used to be if I can't do the perfect workout, I'm not going to do it. So now I'm like, I'm just going to get my ass in the gym. And I don't even know what's going to happen yet, but I'm going to go and I'm going to do something. And I'm going to be better because I just did something. And, you know, I would say I have 4 main pillars to my life. And this is how I balance it. This is the balance part of all of that and how I continue doing it. For me, this is often a faith, family, fitness, fun thing for people. I'm not a religious person. So mine is, it's fit in no particular order, although fitness is number one because it's my health and I wouldn't have any of the other things if I didn't have it. So it's fitness, family, friends, and my profession. So I view the word balance, I think, differently. I don't view balance as like I'm giving the same amount of effort to all of those things all the time. And this is my own personal just life goals. I want to absolutely maximize my potential in all of those things. And I said that a little bit earlier. But even in the orthodontic space, like there are aspects that I want to teach and change the game. I really have a desire to do that. And if you want to be the best at something, there's no way that you can be the best at all of those things all the time. It's impossible. There's nobody in the world that can do that. You know, not that I would ever compare myself to Kobe Bryant, but like when he was at the top of his game, he probably wasn't a great friend and a great whatever, anything else. It was like basketball.
Right.
And he knew that. Not everybody knew it, but guess what? He was the best in the world for that period of time, you know? So outside of something like that, the way I do this is I have mental checkpoints and I don't have a like time interval on doing this, but every once in a while I will just check in with myself and I'm like, okay, have I communicated with my friends lately? How's my relationship? Am I in good shape? And how is the practice going? And if one of those things is suffering, then I check the other ones. And it's like, okay, I'm behind on something I should be doing in the practice and I'm not approving my aligner cases as well. And the team's frustrated because I'm not getting back to them as often. But my relationship's solid. I feel really good in the gym. And I'm happy with my friendships and like no one's missing me or anything like that. It's like, okay, I pull back a little bit on those things for the next few weeks or month or whatever it is. I'm gonna give more of myself to the practice. I'm going to get that back in line and then something else will falter. And then maybe I'm too testy with my wife because I'm stressed myself a little bit too much doing one of those other things. And we're arguing about stupid things that we shouldn't. And then I'll do a mental check. I'm like, okay, why is this happening? Did I put too much effort back into the gym or something else? And it's just an ebb and flow of that all the time. So I think that is how I've done it for years. It took me a long time to get there and to be able to accept that all of those things couldn't happen at full force all the time. But I think if you do it, it's been quite effective for me to handle it that way.
No, it's so well said. And ultimately, that is why I think, especially in our discipline, and let's face it, orthodontists tend to attract, the profession of orthodontics tends to attract the type A+++ personality.
For sure.
And we're like, if I can't do it at 110%, then I'm just not going to do it because I don't want to fail. And when you were talking about, a 7-minute workout or a 10-minute workout, I mean, Mike, there were times I can remember my kids are little. And by the way, it's interesting hearing you speak now, as I am that turn 50 in a couple months here, year-old dad, with my girls that are, one's in college, one's on her way out to college. And it's been great that I've been able to be fit and able to go play sports with them and run around with them and do those things. And I do also agree with the example that it sets. It's important. They see it. And I'm proud. Both of my girls, from watching my wife and I work out and stay fit, both my girls take their fitness very seriously and they take their health very seriously. They both as athletes, and now my older daughter in college recreationally is taking her fitness very seriously. It's wonderful to see as a parent when you set those examples that you have to prioritize your health as well, and your fitness and diet and what you put in your body and how you sleep and all of those things. So yeah, the example it sets, I'm really glad you mentioned that. But there were times where my wife and I would alternate putting the kids to bed at night when they were little and read them a book, and we'd stay, and I would have had a brutally long day, in upstate New York, much like where you are, but even a little worse. The weather, it's cold in the winter, and you'd lay down with them in bed and it's dark, and you read them a story, and we kind of lay there for a song or two with them and then go get up. And I mean, I was just like, the last freaking thing I wanted to do was go to the gym. And I'm a night owl by chronology. I'm not a morning person. So I would do it. I would go at night. I'd haul my cookies to the gym, sometimes through a snowstorm at 9:00 at night to go catch a workout. And it wasn't always the prettiest, and it wasn't always the best, and it wasn't anything I was proud of. And I think that's where social media gets really dangerous for people. They feel like they have to have these social media workouts, and they see people that are like, oh, every workout, they look great and they feel great. No, it's a grind. And some of them are going to suck, and they're going to be painful, but kind of like the Jocko Willink mentality, right? Sometimes you just have to go through those motions. You don't give up. You don't give in. And when you do that, you push yourself responsibly, but with the caveat, which I loved you mentioned, that it's okay if it's not the perfect workout. It's okay if it's not the best one yet, right? Because there's tomorrow and the next day, and it's a long-term process. I think the fact that we both see it that way is really interesting because we've never communicated on that. But I do look at my fitness, not just for how I feel or look now, but for how I'm going to feel and look in 10, 20, 30 years. And that is a really big example, which is part of the reason why the one thing I was not good about when I was in the busiest part of my practice was sleep. Ironically, I was not good at getting sleep, and I cut my sleep, and I didn't even know how much that was hurting me until in this new phase of my career, when I can make my own schedule a little more and have a little more flexibility, started to catch up on sleep. I started noticing things that were starting to feel like they were kind of breaking down, and my temperament and everything was just not quite the same. I didn't know it in it because it's a slow change. But then once I came out of it and was focusing more on my rest, because I didn't ever, my diet or my exercise suffer to that extent, I did notice a difference. So for all of you out there listening who think you can do it on less sleep, I was one of them. And I can tell you now humbly that I was wrong, and I was definitely suffering in ways. Now, that being said, when you have little ones and you're up throughout the night, and that's not what I'm talking about. We all go through that as parents. It was after they were, of school age and sleeping through the night, I stopped respecting my own need to get good sleep every night, and I would just make up for things by just staying up later at night, and had to be up obviously early in the mornings. But I think that's so great that you have that, and it will set an example for people. And really, what you do physically, I admire, I respect. You push yourself hard, and it's not easy, but you'll always do it, no matter what. You'll battle through injuries, you'll battle through times where you don't feel as good, but when you have that vision, you just never give up. The people that I know that are struggling at my age now are the ones that stopped when they were your age and didn't stay with it, because it's hard to pick it back up.
I appreciate that, man. I'll say this, for better or worse, I think this is actually kind of faded a little bit over time with what I've learned, but the reason I was so successful at these things when I was younger is just ignorance for what's supposed to be possible. Like when I ran that mile, that actually was part of me wanting to run a sub 5 mile and deadlift 500 pounds on the same day. And at the time, that was not CrossFit athletes could do that. A lot of them now. but that was not a thing. I had never heard of anyone doing it. And I just literally was like, I'm just going to do it. Like, I have no idea. I've never even come close to running a 5-minute mile.
Wow.
My deadlift wasn't quite there. And I was like, I just made it up and I'm going to do it. So I think that's an important thing. And, you mentioned one other thing. I'll give you one more tidbit on that. I wasn't even part of this conversation, but when I was, the first powerlifting competition I ever did, I'll never forget hearing this because it was a long time ago now and I still very vividly remember it. And there was a guy that was in his 60s and he squatted like 315, which for those listening, that probably sounds like a really high number. In the powerlifting world, it's not. However, at 60 years old, if I'm squatting 315, I'll be pretty happy with that, And I remember someone coming up to him and just congratulating the guy and being like, hey, man, it was similar age. I don't know how old they both were. I'm making a little bit of an assumption, but I knew that guy was in his 60s. I didn't know what the age of the person talking to him. But they said some version of like, hey, I'm struggling to get back into it. Like, I can't believe you lifted that. How did you get back into like lifting that like that at your age? And he goes, I never got out of it. And that stuck with me for a really, really long time. And it will forever. I think about that moment often. It's like, when I'm thinking it's really hard to get back into it, it's way harder than staying with it. Like, it's hard enough to stick with it. And I've dealt with some version of that because of what I said, like I went from hours of training to 10 minutes. And when I finally built a schedule and committed more to it again, even with the situation now, because I'm living what you said, I'm middle of the night. I'm up all the time with my kids. So my sleep's all over the place right now, but I've rebuilt the schedule and I'm in the gym no matter what. Like, I don't compromise on being in there. So I have had at least a little tidbit of what it's like from like going to what I thought was a very high level of fitness to fading. But even though I held on to a lot of it, but to build it back. And I'm thankfully I'm back in a really good groove right now, but it's tough. It's tough to get it back. So that would be my best piece of advice for anyone thinking about that is don't ever get out of it. It's really easy to get comfortable if you miss a little bit of time. And then it's super, super hard to get it back.
It is. Just stay with it in some capacity. And I can tell you, just to encourage you on the other end, having stayed with it, when you get to this side and your kids are older and you can get sleep under control and you have a little more control over your schedule, I mean, I'm in better shape now than I was 10 years ago. Because 10 years ago, practice was crazy. I was just trying to get a few, 3, 4, maybe a week with 5 workouts in if I could. But for the most part, it was kind of weekend warrior, but I never stopped. As tired as I would be, I never stopped. So yeah, stay with it. And then as long as you stay with it and you keep your body in motion, when you get more time and you prioritize it, you'll be able to get in. Now I'm able to work out 6-7 days a week, be able to just kind of push my body a little more even. And it's actually really fun at this age to kind of push those limits and see how far I can go. It's funny when you said about the 60-year-old, years ago it had been like 60. Now I'm like, oh my God, I'm not that. I'm like a stone's throw from 60. It's crazy to think about, but, and I want to be that guy, that's able to lift heavy weights and be strong at that age, but you can't stop. So this has been such a great conversation, Mike. I mean, literally I could talk about this stuff all day, but, it's just so much fun and really just respect what you do. Your openness, sharing everything you do, and you're a real leader in our profession. For people who listen who aren't in the orthodontic world, I'm not overstating that. Mike is a real leader in this field, and people look to him as a young orthodontist. That's really rare that people circle around and admire someone who's so young and new at doing this, because it takes time to really be a proficient clinician, but they respect what you do as a clinician and as a thinker and as a communicator and as a parent now and fitness enthusiast. You're an amazing human. I'm happy to know you, and I'm looking forward to being able to stay in touch and continue to fight this fight. And I mean it when I say I'm happy that you are by my side to be able to help fight some of these battles, because we can't spend all day fighting this stuff. But every now and again, we've got to speak up and let some of these people who are really ignorant on this topic and saying things that really aren't true. And we've got to stand up for the truth on that. And I appreciate that you're there. You're there for that as well. So yeah, thank you so much.
Thanks for having me, man. I really do appreciate it. And on a personal note, like I said, you've helped me a lot, just connecting me with the right people with my son. So I'm very thankful that happened. And I will continue fighting the good fight. I think we're probably in this for a long time, but it matters, and I think it's worth it. And I'm going to keep doing it.
Love it. Dr. Mike DePascale, thanks so much. Really appreciate you, bud.
All right. Take care, man. Thanks again.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.